Good morning, ladies and gentlemen. I would like to thank the organizing committee for the very kind invitation. I would like to thank our chairman. It's a pity Nur Boholz is not here with us today. He's been working, I know he's been working for this Congress for about 2 years, and I hope it's nothing serious. We're going to talk regarding the metabolic workup, who, how, and how often. It's a challenging topic. I hope that in the next 15 minutes to clarify some of all these issues. I have nothing to disclose regarding this lecture. Stone incidence depends on geographical, climatic, ethnic, dietary, and genetic factors. The prevalence rates for urinary stones vary from 8 to 19% in men and from 3 to 5% in women in Western countries. For some areas, an increase of more than 37% over the last 20 years has been reported. The recurrence risk is basically determined by the disease or disorder causing the stone formation. About 50% of recurrent stone formers have just one lifetime recurrence, although in specific stone types, such as cystine stones or uric acid stones, the recurrence rates are significantly higher. Highly recurrent disease with 3 at least recurrences is observed in about 10% of patients. In order to discover the possible underlying causes and diseases in stone formers, metabolic evaluation to facilitate prevention or tailor an adequate therapy is of utmost importance. There is, however, a lack of consensus regarding which patients should be considered for an in-depth metabolic investigation. It also remains unclear when, how, and how often patients should be evaluated. There are several types of stones regarding their composition, and stone composition is the basis for further diagnostic and management decisions. Almost 80% of stones are calcium stones, such as vevelite or calcium oxalate monohydrate, vedellite, calcium oxalate dihydrate or mixed. We should not forget carbapatite. As well, we should not forget brucite stones, while the rest of 20% consists mainly from struvite, uric acid, cystine, etc. Especially for calcium stones, there is lack of knowledge regarding the exact pathophysiologic mechanisms that lead to calcium stone formation, and in many cases it is difficult to clarify the exact leading cause, while for the uric acid or struvite stones or cystine stones, things are rather straightforward regarding the pathophysiology, the subsequent etiology, and the preventive measures. After stone passage, every patient should be assigned to a low or high risk group for stone formation. Stone type and disease severity determine low or high risk stone formers. And in according to the EU guidelines, in this extensive table, we can see all categories of high risk stone formers. A comprehensive evaluation of stone risk in patients should also include the risk for developing chronic kidney disease or end-stage kidney disease, and of course, metabolic stone disease. Urolithiasis can compromise renal function because of the renal stone itself, the renal tissue damage due to the primary condition causing the stone formation, and of course, not to forget the urological procedures that should be carried out in order to solve the problem. Now, the question, does the specific evaluation prevent stone recurrences? Is there any evidence regarding the fact that we should have a metabolic workup? In this study, more than 2,500 patients with at least one laboratory follow-up after initial clinical and laboratory evaluation were followed up for about 2 decades in a specialized kidney stone clinic. And it was shown that patients who remained under active care had significant reductions in stone recurrence and rates of stone-related urological procedures. The result seemed to be directly correlated with lower levels of supersaturation, at least for patients with calcium oxalate stones. Now, for correct classification of patients, two items are mandatory besides the imaging. First, the stone analysis, which is the easiest method for diagnosing stones and should be performed in at least in all first-time stone formers. The evaluation should be done with infrared spectroscopy or X-ray diffraction. Equivalent results may be obtained by polarization microscopy and not with chemical analysis, which is generally deemed to be obsolete. Second, basic laboratory analysis. Biochemical workup is similar for all stone formers. Only patients at high risk for stone recurrence should undergo a more specific analytical program, and stone type is the deciding factor for further diagnostic tests. Specific metabolic evaluation requires, apart from the basics, a 24-hour urine sample, and the urinary parameters measured are detailed in the table and can be adapted accordingly. Now, regarding the urine sampling, specific metabolic evaluation requires collection of 2 consecutive 20-hour urine samples, and the collecting bottles should be prepared with 5% thymol in isopropanol or stored at less than 80 degrees centigrade during collection to prevent the risk of spontaneous crystallization in the urine. Pre-analytical errors can be minimized by carrying out urinalysis immediately after collection. Spot urine samples are an alternative method of sampling, particularly when the 24-hour urine sample is difficult to be collected, perhaps in non-toilet trained children. For the initial specific metabolic workup, the patient should stay on a self-determined diet under normal daily conditions and should ideally be stone-free for at least 20 days. And follow-up studies are necessary in patients taking medication for recurrence prevention. The first follow-up 24-hour urine measurement is suggested 8 to 12 weeks after starting the pharmacological prevention of stone recurrence. And once the urinary parameters have been normalized, it is sufficient to perform this 24-hour urine evaluation every 12 months. Now, all stone formers, independently of their individual risk, should follow preventive measures. The main focus is adequate hydration, allowing for a generous output of urine, normalization of dietary habits following a balanced diet, and adopting a healthy lifestyle with adequate physical activity. Stone formers at high risk need specific prophylaxis for recurrence, which is usually pharmacological treatment based on stone analysis, as I said, and urinary risk profile. This pharmacological treatment is necessary in patients at high risk for stone formation, and the ideal drug should halt the stone formation, should have no side effects, and it should be easy to administer. And each of these aspects is important to achieve good compliance. In this table, there are highlighted the most important characteristics of commonly used medication. And after all this preface, let's see some practical tips regarding metabolic evaluation of the most frequent stones. Metabolic evaluation for calcium oxalate stones consists of usual blood analysis, and in the case of increased calcium levels, we should check for vitamin D, parathyroid hormone to confirm or exclude the hyperparathyroidism, and a 24-hour urine sample. And the most common metabolic abnormalities associated with calcium stone formation are the hypercalciuria, affecting up to 60% of adult stone formers, and hyperoxaluria affecting up to 67% of adult patients, followed by hyperuricosuria, hypomagnesuria, and hypocitraturia. Some calcium phosphate stone formers are at high risk for recurrence. And calcium phosphate mainly appears in two completely different minerals, the carbonapatite and brucite. Carbonapatite crystallization occurs at a pH more than 6.8 and may be associated with infection. On the contrary, brucite crystallizes at an optimum pH levels of 6.5 to 6.8 at high urinary concentrations of calcium and phosphate, and its occurrence is not related to UTIs. Metabolic evaluation for calcium phosphate stones consists of usual blood analysis, and in the case of increased calcium levels, we should check for parathyroid hormone and perform a 24-hour urine sample. Now, regarding uric acid, all uric acid stone formers are considered to be at high risk for recurrence. The uric acid nephrolithiasis is responsible for approximately 10% of renal stones and is associated with hyperuricosuria, low urinary pH, or low urine volume. Chronic kidney disease is something that we should check, and it's frequently observed. Hyperuricemia may be present, but there is only weak evidence for its association with stone formation. Blood analysis requires measurement of creatinine, potassium, and urine acid levels, and urinalysis requires measurement of urine volume, pH profile, specific weight, and checking for uric acid levels. The hyperuricosuric calcium oxalate stone formation can be distinguished from the pure uric acid stone formation by the urinary pH, which is usually above 5.5 in calcium oxalate stone formers and less than 5.5 in urine acid formers. All infection stone formers are deemed at high risk for recurrence as well. Struvite stones represent 2 to 15% of the stones sent for analysis. Stones that contain struvite may originate de novo or grow on pre-existing stone cores, which are infected with urea-splitting bacteria. There are several factors, as we can see, predisposing to struvite stone formation. Blood analysis requires measurement of creatinine, and urinalysis requires repeat urine pH measurements and urine culture. Infection stones contain several minerals like struvite, carbonapatite, and ammonium urate, and the urine culture typically provides evidence for urease-producing bacteria. They increase ammonia ions, they develop alkaline urine. Proteus mirabilis accounts for more than half of all these cases. The crucial point is the eradication of infection after complete stone removal, which is desirable, but we cannot achieve this task all the time. The evidence regarding the duration of postoperative antibiotic administration is something that it's inconclusive. Now, last but not least, cystine stones account for 1 to 2% of all urinary stones in adults, 6 to 8% in pediatric studies. All cystine stone formers are deemed at high risk for recurrence and, of course, for chronic kidney disease development. Blood analysis includes measurement of creatinine, and urinalysis includes measurement of urine volume, pH profile, specific weight, and cystine. Cystine is poorly soluble in urine, crystallizes spontaneously in the normal range of the pH, and the diagnosis is established by the stone analysis. And the typical crystals, the typical hexagonal crystals that we can see here, are detectable in only 1 to 4 to 1 to 5 urine specimens from these patients. Tioprenin is currently the best choice for stone, for cystine reduction. And of course, the main therapeutic option is to maintain a urine pH more than 7.5 and appropriate hydration with a minimum of 3.5 liters per day. I would like to thank you. Concluding the lecture, I would like to welcome you, to invite you in our first national Congress after 4 years due to this pandemic, in this hotel, but in a different hall, we hope. And I would like to inform you that for the first time, and we are one of the very, very few European countries, we are going to organize, under the auspices of the European School of Urology, first urology bootcamp for first year urology residents. Thank you.